Students, so my voice is starting to come back, and so we're going to try to see if I can make it through this lecture. Immunomodulating drugs are medications that therapeutically alter a patient's immune response to malignant tumor cells. They are also drugs that modify the body's own immune response so that it can destroy various viruses and cancerous cells. They're a fourth part of cancer therapy in addition to surgery, chemotherapy, and radiation. They're also used for other diseases like autoimmune diseases, inflammatory diseases, and some infectious diseases as well. Just as a review, the immune system has two components that work together to recognize and destroy the foreign particles and cells in the blood and other body tissues. The humoral immunity are mediated by the B cell functions, the antibodies, and the cell-mediated immunity is mediated by the T cell functions. In addition, we have tumor antigens. These are like a marker that says there is a tumor here, there's abnormal cells. And these tumor antigens are things that we can actually draw from the blood and see that there is a cancer present. This is things like the PSA that we do on men to sense whether or not they have prostate cancer. You know that the antibodies attack the tumor cells, and that's from the humoral immune system. They are the primary antibody production. And those are the B lymphocytes. And then again, that's the cell-mediated immune system, and those are the T cells. And there's a synergy in action of these two systems so that our bodies do not become so sick. And so just a reminder again that the B cells, which are from the bone marrow in humans, have the memory cells that remember the antigens. They also have plasma cells, and the plasma cells are where we make the antibodies, the different Igs. The IgAs are found in saliva, breast milk, colostrum, and the secretions in the GI and respiratory tracts. The IgD, they don't really know much about them, but they do know that in some parasitic infections, we have an increase in IgD. IgE mediates allergic reactions. IgG is the main antibody that gives us long-lasting memory. And IgM is the primary antibody that's produced after the initial contact with an antigen. So I know this seems a little redundant right now because we keep kind of saying the same thing over and over. The B lymphocytes, they originate in the bone marrow, hence bone marrow, B lymphocytes. And when a foreign substance, an antigen, is present, these differentiate or they turn into plasma cells, which in turn produce the antibodies. Antibodies are immunoglobulins that bind to a specific antigen. And they also form an antigen-antibody complex that inactivates the disease-causing antigens. Monoclonal antibodies are antibodies that a single plasma cell makes that are all identical to each other. And then we have the memory cells that remember those various antigens and activate that humoral immune system. Within the cell-mediated immune system, we have the T cells, which they originate in the bone marrow, but they mature in the thymus gland. And the thymus gland, sits up on top, sort of on top of our lung area. And in babies, we can actually see the thymus on an X-ray, but in adults, it kind of shrinks down, and so we don't notice it so much on an X-ray. There's 3 types of T cells with different functions. The cytotoxic T cells directly kill their targets by causing cell lysis or rupture. So they're like the assassins of the T cells. Those cells just rupture and break open. The T helper cells direct the actions of many other components of the immune system. As they're sort of like the ones like, hey, you guys, over here, come help. The T suppressor cells serve to limit or control the immune response. So, the T helper cell is saying, yeah, you guys get over here and help, where the suppressor is going, okay, we have enough. We don't need more volunteers. You guys can head on back to where you belong, okay? So that it doesn't overwhelm the body. So just as I was just talking about, in a healthy immune system, there's about twice as many helper cells as suppressor cells at any one time because, we're being attacked constantly by bacteria and viruses and parasites and all sorts of things. Not to mention that our cells have the potential to turn into cancer at any time as they're dividing. Fortunately, we usually take care of those cells, those killer cells, kill them off before they become full-blown out cancer. And that's why we need more of those helper cells. The suppressor cells, we don't want to be suppressed too much because if the T cells are suppressed too much, then we're going to be more prone to getting cancer. We're going to be more prone to getting infections. And if you look at some of these chronic diseases where people have immune suppression, often you can look at the overaction of the T suppressor cells as being the cause. Some of the other cells of the cell-mediated immune system help to destroy cancer cells, and they get rid of the unhealthy cells in the body. And we know that the macrophages are derived from monocytes, and the natural killer cells and the polymorphonuclear leukocytes are other examples of cells that are taking care of these unhealthy cells within the body. So the bottom line to these biologic response or modifying drugs is that they alter the body's response to diseases like cancer, the autoimmune diseases, the inflammatory and the infectious diseases. And within that group, there's subclasses like the hematopoietic drugs, the interferons, the monoclonal antibodies, interleukin receptor agonists and antagonists, and the disease-modifying antirheumatic drugs, or the DMARDs. And then there's a miscellaneous group. And we'll talk about drugs in each one of those. The mechanism of action for these biologic response modifying drugs is that they enhance or restore the host's immune system defenses against the tumor. They also have a direct toxic effect on tumor cells, which cause them to rupture or lyse. They also have adverse modification of the tumor's biology. So it makes it harder for that tumor to survive and reproduce. I do want to make a clarification as far as this idea of a tumor, because in some cases what we're talking about is not a true tumor like a cancer tumor. Sometimes what we're talking about is just abnormal cells that exist within the body. And if you think about it, for instance, somebody with psoriasis, in psoriasis we have an overproduction of skin cells, and so that's how they get the plaques and all of the um, irritation and everything that goes along with it. That in and of itself, it would normally not be considered a tumor, but yet in a way it is, because a tumor is a mass of cells that are reproducing inappropriately. So make sure that you understand that tumor doesn't always mean cancer. Tumor can just mean that there's an abnormal accumulation of cells. The therapeutic effects of the biologic response modifying drugs is an enhancement of hematopoietic function. There's also a regulation or enhancement of the immune response, including the cytotoxic or cytostatic activity against cancer cells, and the inhibition of metastasis, which means people would not metastasize as easily, the prevention of cell division, or an inhibition of cell maturation. So going back to like the psoriasis person, uh, these drugs would cause those cells not to divide as quickly, and it would inhibit the cell from maturing as quickly. Hematopoietic drugs are drugs that promote the synthesis of the various types of the major blood components by promoting the growth or differentiation or function of their precursor cells in the bone marrow. And it's produced by recombinant DNA technology. They're used to decrease the duration of chemotherapy-induced anemia, neutropenia, and thrombocytopenia. And they enable higher doses of chemotherapy to be used. And there's a lot of other uses as well. For instance, a patient that is a Jehovah's Witness who doesn't want to receive a blood transfusion may be given some of these hemopoietic drugs prior to surgery so that their body starts to produce more red blood cells, so that whatever blood loss they have during the surgery does not have to be um, replaced by a transfusion. And it would still mean that they lost that blood, but they could give them volume to take care of the volume loss, and their body would already be starting to replace the lost blood because of having gotten the hemopoietic drugs. Another use might be in infants, the nadir, or the lowest point before the body starts producing more red blood cells, happens at about 6 to 8 weeks after the baby's born. And so with a premature baby where we're taking off a lot of blood with them, if we don't want to have to transfuse them, which we try not to do transfusions in babies if we don't have to, we can give them hemopoietic drugs as well, so that their body starts producing their red blood cells before they hit that nadir. These are examples of those hemopoietic drugs. The erythropoietic drugs are epoetin alpha and dar-epoetin alpha. The colony stimulating factors, or CSFs, are filgrastim, pegfilgrastim, and sargomostin. And the platelet promoting drugs are oprelevkin and romplistin. The way that they work is they decrease the duration of chemotherapy-induced anemia, neutropenia, and thrombocytopenia. They allow for higher doses of chemotherapy. They decrease bone marrow recovery time after bone marrow transplantation or irradiation. And they stimulate other cells in the immune system to destroy or inhibit the growth of cancer cells, as well as virus or fungus infected cells. Filgrastim or Neupogen is a granulocyte colony stimulating factor, and it stimulates the precursor cells for the type of white blood cells, which includes basophils, eosinophils, and neutrophils. And it's administered before the patient develops an infection. So in other words, this is something that we're going to give a cancer patient before they get an infection. Pegfilgrastim or Neulasta is a longer acting form of filgrastim. Sargramostim or leucine is a granulocyte macrophage colony stimulating factor, and it stimulates the bone marrow precursor cells that make both granulocytes and phagocytes. So in other words, it stimulates the production of the precursors of monocytes. It's indicated for promoting bone marrow recovery after autologous or allogenic bone marrow transplantation in patients with leukemia and lymphoma. Oprelvecin or Numega is both a hematopoietic drug and one of the interleukin 2 drugs as well. It enhances synthesis of platelets, and it's indicated for the prevention of chemotherapy-induced severe thrombocytopenia and the avoidance of a need for platelet transfusion. So think about the fact that when you're getting chemotherapy, it shuts the bone marrow down as a whole. So you're at increased risk of bleeding because you're not producing platelets. So this is given to prevent that from happening. And it stimulates the bone marrow cells, specifically the megakaryocytes, and those megakaryocytes eventually become platelets as they mature. So I was trying to figure out why we weren't talking about epogen, the erythropoietins, but then I remembered that we talked about those when we were talking about the anemia drugs. So the indications are for of these hemopoietic drugs are for patients who have experienced the destruction of bone marrow cells as a result of cytotoxic chemotherapy. Also for to decrease the duration of low neutrophil counts, thereby reducing the incidence and duration of infections, to enhance functioning of mature cells of the immune system, and that results in a greater ability to kill cancer cells as well as viral and fungal infected cells. And they enhance red blood cell and platelet counts in patients with bone marrow suppression. They also allow for higher doses of chemotherapy because those higher doses of chemotherapy causes the bone marrow to shut down. So by stimulating it, we can give a higher dose that sort of balances it off. So here's something to think about. A patient's chemotherapy is ended at 6 o'clock on a Tuesday afternoon. When is it the appropriate time to start therapy with filgrastim? 1800 on Tuesday, right after we're done. 6 o'clock in the morning on Wednesday, 6 o'clock in the evening on Wednesday, or a week later at 6 o'clock on Tuesday? Well, the answer to this one is that we can start it within 24 hours. Filgastrin and sarcomestem have significant drug interactions when they're given with the myelosuppressive anti-neoplastic drugs. So typically, they're not given within 24 hours of the administration of the myelosuppressive anti-neoplastics. So if we're finishing at 1800, we can start the next day at 1800 with the dose of filgastrin. So I want you to think about a lot of these drugs and remember that they're given parenterally. In some cases, they actually are an IV infusion, and in other cases, they're given as an IM injection. And so there are side effects that you have to worry about them. Not only that, but they are DNA recombinant drugs. So basically, they aren't all that different from having somebody else's stimulating factors being put into your body. So you have to worry about adverse effects. Usually for these drugs, they're mild. Some of the more common ones include fever, muscle aches, bone pain, and flushing. I have to say that of course, babies don't raise an immune response very well, but I really haven't seen it in the babies, and the adults that I've talked to that have been on these medications really have not had a lot of side effects associated with them. So I remember when the interferons came out, and this was something that was majorly wonderful because up until that point, we knew that our bodies produced interferon, but we really didn't know how to allow that to be used. So what they are is proteins with three basic properties. They're antiviral, anti-tumor, and they're immunomodulating. They're used to treat certain viral infections and cancer. And there's alpha, beta, and gamma interferon. Like so many other ones that we're going to talk about today, they're recombinantly manufactured substances that are identical to the interferon cytokines that are naturally present in the human body. Again, remember that makes them, even though they're synthetically or they're not synthetic, they are natural, but the way that they're produced, it means that you have to be careful with them, and you have to realize that they're going to have potential side effects associated with that. The IFNs protect the human cells from a virus attack. They prevent cancer cells from dividing and replicating, and they increase the activity of other cells in the immune system like macrophages, neutrophils, and natural killer cells. Interferons in our bodies are stimulated to be produced when we run fevers. It's one of the ways that our body contains the viral infections that we get. How they affect the immune system is that they restore the immune system's function if it's been impaired. They augment the immune system's ability to function as the body's defense, and they inhibit the immune system from working in some ways, and that's helpful when it's given for autoimmune disorders. Some of the indications for interferon include viral infections like genital warts and hepatitis, cancer treatments for chronic myelogenous leukemia, follicular lymphoma, hairy cell leukemia, Kaposi sarcoma, and malignant melanoma. They also use it for multiple sclerosis, which is an autoimmune disease. The adverse effects that are associated include flu-like effects, so fever, chills, headache, myalgia. Remember, interferon naturally comes out when we are having these type of reactions. And the more we have these flu-like symptoms, the more interferon our own body produces to control the viral infection that we have. There's a dose-limiting adverse effect, and that's fatigue. Again, think about when you're sick. You feel tired. You just want to sleep. And so these interferons in effect are causing the body to have the same healing properties of sleep that it would have if you were sick. Other adverse effects include anorexia, dizziness, nausea, vomiting, and diarrhea. So these are all the different types of interferon, and I think you all can read the list on your own, and so I'm not going to try to read through every single one of these today. Monoclonal antibodies are used in the treatment of cancer, rheumatoid arthritis, multiple sclerosis, also known as MS, and organ transplantation, and in some cases, other viral infections like RSV. It's actually not so much a treatment for RSV as it is a preventative indication with RSV. Specifically, they target cancer cells and have minimal effects on the healthy cells, and there's fewer adverse effects than traditional anti-neoplastic medications when used for that. So these are examples of the various monoclonal antibodies. I'm not going to go into each one of these, but if you notice, most of them end with this UMOB at the end. And so that's one way that you know that this is a monoclonal antibody. One thing that I wanted to point out to you is pavizumab, which is Synagis, and we're going to be talking about that when we get into PEDS next semester. And it's used for the prevention of RSV infection in premature infants, and it's given to them on a monthly basis. The other thing I want to talk to you about, though, as we're talking about these medications, is none of these medications are cheap. They're made by very new technology, and as such, they charge an arm and a leg for them. A dose of palivizumab is $900 a dose. If you don't have insurance to cover it, you are pulling out $900 every month through the RSV season for your baby. So just to give you a general idea of the fact that these are not cheap drugs and or cheap technologies that we're using to prevent these different diseases. So before we get into this question itself, I want you to notice that they're using the word mob, which, remember, that's how all of these monoclonal antibody drugs they end with MOB, which stands for monoclonal antibody. So that's another way to help remember them. So which statement regarding the use of MOBs in the treatment of cancer does the nurse identify as being true? MOBs are not as effective as other chemotherapy drugs. MOBs have few adverse effects. MOBs may cause flu-like effects but do not cause the typical adverse effects associated with chemotherapy. MOBs are only used in cases of last resort when other chemotherapy drugs have failed. Well, the answer to this one is C. Because these drugs only target cancer cells, they don't have the adverse effects that are typically associated with chemotherapy. However, they do cause some acute symptoms that are similar to the classic allergy or flu-like symptoms. And as a result, these symptoms have to be managed while they're getting therapy. Interleukins are a natural part of the immune system, and they're classified as lymphokines. And they also can be classified as hemopoietic drugs. Leukocynes are another form of this, and they are soluble proteins that are released from activated lymphocytes like natural killer cells. They're have beneficial anti-tumor action, and here are the list of some of the interleukin receptor agonists. There's several different kinds of interleukins, and each has its effect on the immune system. There's anti-tumor action, which the interleukin 2 is produced by activated T cells in response to the macrophage processed antigens and secreted interleukin 1. Interleukin 2 derivative, which is aldesleukin, stimulates and restores the immune response, and it binds to the receptor sites on T cells, which stimulates the T cells to multiply. Lymphokine is activated killer cells, and they recognize and destroy only the cancer cells, and they ignore the normal cells. Anakinra is a recombinant form of interleukin 2. So when we're giving this, these natural killer cells will go in and kill just the cancer cells and leave the normal ones alone. And as you know, one of the problems with chemotherapy is that it tends to go in and just kills everything in sight. And so that makes it so that this is more specific to just the cells that we want to kill. Aldesleukin or Proleukin is given for the treatment of metastatic renal cell carcinoma and metastatic melanoma. It also has some off-label uses, including for treatment of HIV infection and AIDS, and for non-Hodgkin's lymphoma. So remember, off-label means that the FDA has not approved it. Anakinra or Kineret is an interleukin 1 receptor antagonist, and it's used to control symptoms of rheumatoid arthritis. So remember, an antagonist is making something not be produced. One of the side effects of interleukins is something known as capillary leak syndrome. It is a form of severe toxicity, specifically to aldesleukin therapy. the capillaries lose their ability to retain their colloids in the blood, and so then these substances are leaked into the surrounding tissue. Now remember, the colloids are how we keep fluid into whichever compartment of the body we want them to be in. So if the capillaries are leaking their colloids out into the interstitial areas, then what's going to happen is we're going to have massive fluid retention. We're going to have fluid out of the circulatory system. This is going to lead to respiratory distress, to heart failure, can lead to myocardial infarction, dysrhythmias. And the good news is once the interleukin therapy is discontinued, it reverses. But it's definitely something that as a nurse you have to watch for the early symptoms of it so that you don't get your patient into respiratory distress and heart failure and all the other things that go along with it. We've already talked about rheumatoid arthritis in patho, but just as a reminder, it's an autoimmune disorder that causes inflammation and tissue damage in the joints. And our little skeleton here is basically showing us what joints we're primarily concerned with. The diagnosis is primary symptomatic, and the treatment consists of nonsteroidal drugs, anti-inflammatory drug or NSAIDs, and DMARDs. Osteoarthritis is another type of arthritis, and it's associated with age-related degeneration of the joint tissue, which causes pain and reduced function. Disease-modifying antirheumatic drugs, or DMARDs, modify the disease of rheumatoid arthritis, and they exhibit anti-inflammatory, anti-arthritic, and immunomodulating effects. They inhibit the movement of various cells into an inflamed, damaged area like a joint. They have a slow onset of action over several weeks versus minutes to hours for the NSAIDs. So when we start giving DMARDs, think about the fact that you're going to have to educate your patients that it's going to take a while for them to start working and not to get discouraged. They're also referred to as slow-acting anti-rheumatic drugs. We also have some non-biologic disease-modifying anti-rheumatic drugs, which include methotrexate. And if you remember, methotrexate is also a chemo drug. And but this particular chemo drug has anti-inflammatory properties to it. Lufutamide is another one. Hydroxychloroquine, if you remember, that one is actually for the treatment of malaria, but it also has some anti-inflammatory actions. And sulfasalazine is another non-biologic disease-modifying anti-rheumatic drug. So again, the list of the various DMARDs, notice that they also tend to end with the MOBs, except that we have the etanercept and the abatacept and anakinra, which, if you're paying attention here, you are recognizing that these also fall into some other classifications. So this is where you should be starting to remember some of the commercials you've been watching. And I know that usually we just sort of turn off those commercials and we don't pay any attention to them. But this is the one time that paying attention to commercials may not be a bad idea, because all these different drug commercials usually will tell you what the drug is. They usually will say the name of the drug, not just the brand name, but the generic name. So you can hear how it's supposed to be said, which I don't always get that right. And then they also will tell you what the drug does, and they will also tell you what kind of adverse effects you need to watch out for with it. So just, a little thought when you're thinking about studying for pharmacology, but also to reinforce that information after pharmacology class is over, because you still have to know about these drugs as a nurse. So etanercept, or Enbrel, it's used to treat RA, including juvenile RA, which is a different disease process, and psoriasis and psoriatic arthritis. The patients must be screened for latex allergies because some of the dosage forms may have some latex in it. The onset of action is 1 to 2 weeks. So you've got to tell these patients that, yeah, you're going to get this today, but you're not going to see any results of it for 1 to 2 weeks. It's contraindicated in the presence of active infections. So you need to screen them and make sure that they haven't been exposed to anything recently. Also, it may cause a reactivation of hepatitis and tuberculosis if this is something that they have a history of. Abatacept or Orencia is used to treat RA. We need to use caution if the patient has a history of recurrent infections or chronic obstructive pulmonary disease. Patients need to be up to date on their immunizations before they start therapy, because we've got to make sure that they don't get sick while they're on this. It may increase the risk of infections associated with live vaccines, so definitely we want to make sure that they've had their immunizations. And also it may decrease the responses to vaccine. That's why we want to make sure that their immunizations are up to date before we start giving this. So the nursing implications that's associated with all these different biologic modifying medications is that we need to assess for allergies, especially for allergies to egg proteins, IgG, or neomycin. We need to assess for conditions that may be contraindications. We want to assess blood counts, perform cardiac, renal, and liver studies. And we want to assess for the presence of an infection, because with most of these medications, it can increase the risk of them developing an infection. We want to follow specific guidelines for the preparation and the administration of the drugs. In some cases, it may be that you're not supposed to shake it before you give it. Or that it has to be kept in a refrigerator. And so you need to warm it up with your hands like insulin before you give it. So you need to make sure that you follow the guidelines. And then, of course, we're going to monitor the patient's response during therapy. We want to teach the patient that they need to report signs of infection immediately. Things like a sore throat, diarrhea, vomiting, or a fever of 105 or higher. I was talking to a neighbor, And we were both talking about the fact that when we start coming down with a viral infection, we don't go rushing off to the doctor because they're not going to do anything for us because it's viral. But in the case of drugs like this, patients need to be told to not ignore these things, to not feel like that the doctor's not going to do anything because it's just a viral infection, because these drugs are increasing their risk of these infections being much more severe. We want to monitor for therapeutic responses, which are going to be a decrease in the growth of a lesion or a mass, improved blood counts, and the absence of infection, anemia, and hemorrhage. And also, we want to monitor for adverse effects. So, a 40-year-old patient is seen in the clinic, and she's been newly diagnosed with RA. Which medication does the nurse anticipate being ordered for the patient? Methotrexate, adalimumab, infliximab, or etanercept? Well, the correct answer in this one is A. When you're newly diagnosed with RA, first they're going to try methotrexate. And the recommended therapy is non-biologic DMARDs, and it usually begins with methotrexate or leufonamide for most patients. The biologic DMARDs are generally reserved for patients whose disease does not respond to methotrexate or leufonamide. And the biologic DMARDs include etanercept, infliximab, adalimumab, abatacept, and rifleximab. So if you think about it, again, back to those commercials that you're hearing all the time. They'll say this drug is for like etanercept. They'll say this is for patients where methotrexate has not been effective. So again, it's back to the watching some TV is not a bad thing because you can pick up things that you need to know for pharmacology class during the time you're watching TV. So before administering methotrexate, it's most important for the nurse to assess the patient for allergy to eggs, congestive heart failure, latent tuberculosis, or hypothyroidism. So on this one, it's latent tuberculosis. Before administering the DMARDs, it's important to assess the patient for contraindications. And those are things like active bacterial infections, active herpes, active or latent tuberculosis, and active or chronic hepatitis B or C. So something like tuberculosis, they may hold off giving the DMARD until the infection has completely been cleared up. And the same with bacterial infections. So a patient is scheduled for discharge. Which information does the nurse include when teaching the patient about methotrexate therapy? You can expect to develop mouth sores that will improve with time when taking this medication. Administer the methotrexate injection daily in the morning. C. Mix the methotrexate with sterile saline before administration. Or D. Administer the methotrexate subcutaneously into the thigh, abdomen, or upper arm, rotating the injection sites. Well, the answer to this is D. Methotrexate should be administered subcutaneously into the thigh, abdomen, or upper arm injection sites. Methotrexate should not be administered with other solutions and without use of a filter. Methotrexate is given weekly. The development of stomatitis should be reported to the prescriber immediately because that is a profound adverse effect. It means that the dose is too high because you're actually getting chemotherapy symptoms of the medication. And again, remember what I was saying, a lot of these medications actually are given parenterally. So you are going to have to teach the patient how to give these medications as well. And remember too that these sites that we're showing are the same sites that somebody with diabetes is going to be given their insulin. So if this person was diabetic as well, you would want to make sure that they were not only rotating sites, but not rotating them into the areas where they're giving their insulin. And finally, the patient improves within the first 3 months of treatment with methotrexate. 6 months later, the patient experiences worsening symptoms. The prescriber will most likely order which monoclonal antibody for the treatment of RA? Adalimumab, which is Humira, trastuzumab, which is herceptin, rituximab, which is Reduxan, or citabamab, which is Erbitux. And the answer on this one is A. Adalimumab or Humira is indicated for the treatment of severe progressive RA for which RA therapies have failed. Trastuzumab is indicated for the treatment of breast cancer. Rituximab is used for the treatment of non-Hodgkin's lymphoma, and canakinumab is indicated for the treatment of metastatic colorectal cancer. So those would be inappropriate for the treatment of RA.